Looking to grow your behavioral health practice and reach more clients who need your help? We have just the solution for you. Psych Hub Provider Learning Hubs are your answer. We will train you in the greatest information on evidence-based practice delivered by industry experts in a state-of-the-art way. And at the end of it, you will earn a certification in how to use these interventions to treat anxiety, depression, insomnia, you name it. And then when you finish, you unlock a whole library of resources for ongoing learning for you as the provider, but to share with your patient. How great is it to let your patient know in a quick video, here's what to expect from your therapy session. And then any exercise or activities that happen in session, we have videos to help reinforce those skills at home for your patients, as easy as just sending a quick text or emailing them. It is a revolutionary new way to really get people through treatment, getting the best symptom results, and engaging your patient along the way. Visit psychhub.com/learning to get started. Hi, I'm Marjorie Morrison.
And this is Patrick Kennedy.
And you are listening to the Psych Hub podcast, The Future of Mental Health. Hello, everybody. I know I always say that we're in for a treat, but really, we really are today. I can't wait for you to meet Dr. Carney and hear from her. She's just so incredible. She's the Chief Medical Officer of Magellan Health and the Chief Medical Officer of Magellan RX Management. She's a board-certified internist and psychiatrist. I mean, that's a rarity. You don't hear that every day. So she really comes at mental health from a whole different perspective than an internist might or a psychiatrist might. She joined Magellan in 2016, and her experience spans across all different types of our system, from Medicaid, Medicare, the exchange, plus commercial populations. She understands things at depth, so she's a really perfect person to help us understand what's going on. She's always been passionate about medicine. In fact, I love these kinds of stories because she went into it from her Aunt Rita, who was a nurse who taught her when she was young how to feel for her pulse. Her calling was toward the healing arts, but she loves to write, and her career as chief medical officer really helps her marry the two. Her life lessons, as we're going to learn, are walk it off and everything in moderation. And she's going to share why COVID-19 has unfortunately been the perfect storm for mental illness to fester and flourish in a terrible way. So I'm excited to get started. Can't wait for you to hear this interview and this great conversation. And let's meet the fabulous Dr. Carney. We are in for a great experience today meeting with Dr. Carney. Welcome.
Thank you so much.
Just for starters, our listeners may not know a lot about Magellan Health. Do you mind sharing a little bit about the company and then the work that you do and really what is a chief medical officer and what kind of work you do there?
I would be happy to. So let's start at the top with Magellan Health. Magellan Health is a company that's composed really of two companies, Magellan RX Management and Magellan Healthcare. Inside of Magellan RX Management sits businesses that work with state governments on pharmacy benefit administration, specialty pharmacy and medical pharmacy programs, as well as just traditional PBMs. Sitting inside of Magellan Healthcare are Magellan BH, our behavioral health, Magellan Specialty Medicine, and Magellan Federal, which provides services to military men and women throughout the world. So I have the great role of being CMO over both of those. And also I still serve as CMO over Magellan RX Management, which is an incredible thing because these are really different ways and different perspectives of looking at what's happening in healthcare today. A CMO really is a jack of all trades. We do all kinds of things and get pulled into many different things, but my key focuses are on innovation, strategy, quality, the kinds of things that will bring clinical programs to our members. This is not a role where I look at just doing utilization management kind of activities, but rather what are the value added activities we as a managed care organization should be doing to make the lives of our members better.
So Dr. Carney, it's great to talk to you and to really hear from your perspective as having been involved with state government and the way state government basically contracts with companies like Magellan. So you have a good perspective that you're kind of bound by the requirements of an RFP. But let's say an RFP were to require you to incorporate housing supports, employment supports, peer supports, things that you've kind of written about as being huge multipliers in terms of the real life outcomes for the patients that you're seeing. Could you talk a little bit about how you see that kind of policy shift starting to take place and kind of where you see it taking place?
Sure, I see it taking place across the country, somewhat state by state in one level or another. Some states are just getting into it in terms of providing, say, educational support for the providers, and something that I know Psych is very much engaged in right now. Other states are moving all the way to providing supports from individuals who are, say, leaving incarceration and need transition services into care, all the way to states providing housing supports. I think the key message here is that this is not something that only the managed care organization can do, only the state agency can do, only community groups can do. It really speaks to the need for a comprehensive and cohesive partnership between all of the parties involved. People can't get lost in the system. People shouldn't fall through the cracks. And we have to figure out how to do that the right way to ensure seamless transitions of care and safe places for people to land.
Let me ask about a way that we can really move this transformation forward by maybe using some of the opioid settlement dollars to prime the pump, so to speak, in getting these different stakeholders to work together in a new paradigm. Um, I know you are active with the opioid technical expert panel, and I'm wondering if you were to kind of design a way of spending a chunk of those dollars in the settlement to do kind of what we try to do with tobacco
Mhm.
in the tobacco settlement. But frankly, most of those dollars obviously got eaten up by state budgets and the dollars redirected as opposed to going to real kind of addiction screening and early intervention. How would you, what would be some of your ideas if you were to be able to have a heart to heart with the judge overseeing that case and say, here are the things that I would do that could be real force multipliers, leverage change across these various agencies that sometimes get stuck in their own rut as opposed to having a change opportunity like this and really incentivize them to move in a different direction.
So, the first thing I would do is take an approach like we take with innovation, which is there needs to be a team that sits outside the usual structure. Often, you hear the phrase the immune system of the company. Well, the immune system of state agencies is there as well. And so I think you have to have a group of innovators sit outside the company and be held responsible for the budget and the outcomes of these programs. I don't think we can get anywhere until we shore up the number of providers and the skill of providers able to take care of individuals with opioid use disorder and, frankly, other substance use disorders. They're hand in hand. And so, whether that is in funneling money into bringing forward new programs of education in grad school or med school and residencies, or retraining individuals who have skill sets that are basic skill sets but really need to be retooled to take care of this population, because the challenges of the population are unique. Opioid use disorder is fraught with comorbid behavioral health conditions as well as comorbid medical conditions. And so you really have to think about whole person approach to care. And I would move that into sort of that third platform. So sit outside the agencies, get the right workforce in place, look at whole person care. So, as a med psych doctor, I can tell you the individual with opioid use disorder as it is at risk for infection from needle injection, at risk for everything then related to the infection, at risk for HIV, AIDS, at risk for hepatitis C, you name it. There are physical complications that we have to take care of at the same time, because ultimately these feed into each other. And the case where that's the most prominent is in chronic pain. So the cycle of addiction with chronic pain is very real. So whole person care and programming is the next. The next step along that line is to use evidence-based practice. There are many evidence-based practices that do work, whether it's medication treatment, whether it's contingency management, whether it is linking from residential programs into directly into solid outpatient programs without just saying, you've done your 30 days, good luck. We have to have that kind of continuum of care for individuals to step down into. And then finally, it is meeting the individuals where they're at. So if that's in an emergency department at 2 in the morning, if that's in the primary care office, if that's in a college counselor's office, we have to know and be able to identify and provide services at the time the individual needs them. We don't want to lose that moment in time where they want help. We need to be able to be there to get that help. So design using those dollars to design those kinds of programs, not an 8 to 5 clinic, but let's really be creative in how we get out there and reach people. And then the final one is one that's really near and dear to my heart, which is doing data driven interventions. So I can look at population health data and come up almost immediately with a list of people who are at high risk. I compare that with genetic information to look at biologically who might be at a higher risk for addiction, and say to an orthopedic surgeon or a dentist, don't start this person on opioids, or if you do, do it the right way in a judicious way so that we can avoid creating addiction newly.
But my experience is that I can tell my healthcare system and every doc that I come in encountered with that I'm allergic to not only penicillin, of course, which they always ask, but I add I'm allergic to opioids, and they all look at me funny. They don't know
Right.
how to or where to put that in the EMR. It seems to me the EMR is sacred ground. If we don't figure out how to embed addiction screening and treatment somewhere in that real estate, we'll always be kind of working around the margins. What are you doing to try to help us transform that EMR as a vehicle to change the whole system?
A couple of things come to mind immediately in what we've been working on. I want to digress really quickly. I work in an FQHC, and when I first started there, just as an aside, something that I think is really important to give back and do. And when I first started there, their EMR was divided by a firewall between physical health and behavioral health, and neither set of providers even knew what medication the others had prescribed. That was the first order of business I had, was to take down that firewall and say we are in a setting of holistic care and can and should be doing holistic care. So from that approach, there is something that gets in the way every single time, which is a misunderstanding of the regulations around protected healthcare and protected healthcare information. So, whether that is lobbying with our federal and state agencies to make those regulations something that still may protect the individual's rights, we have to look at those rights as getting the best healthcare as well. And where we can expand that type of regulation to ensure that information can be documented in the chart. Even if we have the best regulations in place to support that, until we educate healthcare providers about how to interpret the laws and the regulations, we'll never get there. I can tell you over and over and over again that that is one of the biggest barriers. We have behavioral health over here, we have physical health over here. Never the two shall speak to each other. And we miss the right thing to do time and time again because of that. So, our healthcare providers really need to be educated about the latest regulations, the interpretation of those regulations, and what they can and should be doing with that health information to get to the best care.
I totally agree with you. And much to the chagrin of many who are addiction advocates who kind of remember those days when having that information, what they felt was too public could really jeopardize themselves kind of legally. Um, I certainly understand that history, but like you, I think it's a life and death issue for people like myself who
Mhm.
could be on medication. I was on medication assisted treatment for some time. You know, if I were unconscious because of an accident, came into an ER, they didn't know that they could kill me.
Right.
And this is really serious stuff. And so I appreciate your work on that. Let me ask you about these regulatory changes. There's some like advanced directives that I'm really in favor of us pushing across the country because short of us identifying and risk stratifying those populations that are most in need of early kind of attention, we have people who do go to treatment who when they come out and they are better should be making decisions about their future of treatment when they have the insight to their illness and can
Mhm.
make those decisions in their own best interest. It seems to me we also need to educate the public about this and even facilitate guardianship, family courts, conservatorship type provisions, especially if we don't want the criminal justice system to be the de facto intervener, if you will, with these illnesses. Tell me about what you're seeing out there in terms of those important changes in the way we engage people with these illnesses.
Unfortunately, I'm not seeing the use of advanced directives spreading very widely in this direction yet. To be fair, I don't see the use of advanced directives spreading necessarily as widely as they should be in all healthcare settings today. So I couldn't agree more with your idea and that concept, not only in the addiction space, but in the broader behavioral health space for someone, say, who has bipolar disorder and quickly can lose insight in a manic episode. The importance of knowing what kind of treatment they would prefer and need, whether addiction, behavioral health illness, or physical illness, is really critical. So, expanding the concept beyond knowing whether or not I want to be on a ventilator to whether or not I want to be on MAT or receive X, Y, or Z in terms of treatment, I think is really critical. And that message is something that if we carry in such a way that doesn't discriminate a physical health choice about an advanced directive from a behavioral health or addiction choice, it's all the same, will be all the better. And I think moving that forward.
Well, I look forward to supporting you in that effort and think that given your partnership with Centene, which is an enormous aggregator of state benefits across the country in various states, that you have the ability to move this kind of systems approach change. I heard you mention, contingency management. That makes me so happy because you never hear people talk about contingency management, even though it is, in my view, one of the best evidence-based tools to get people to change their behavior. Uh, Talk about your vision of how we can expedite and spread that as a tool for people who have these very difficult illnesses that they need to try to break out of through cognitive behavioral therapy, but how contingency management can support that.
Contingency management really is a fancy way of saying rewarding positive behaviors and providing supports to help people lead a path to get to those positive behaviors. And so it's a critical part of addictions care. It has been shown over and over again to be something that works. So, in the ideal world, I think you have to pair all of the best evidence based practices together. And that's where I kind of go back to that idea of looking at whole person care. So, in this case, whole addiction care would include the right evaluation and getting medication assisted treatment, supported by cognitive behavioral treatment, supported by care in the community so that individuals can live in the communities to which they will return for their treatment and be able to have the behavioral and environmental supports in place, supported by contingency management to lead that kind of ultimate behavioral change and reward and earning and getting that individual to understand that they can get there. I think it's really part of a multifactorial set of services that, if applied time and time again, will work.
As you know, with this population, I'm speaking as someone who firmly is in the middle of this population, having suffered addiction, mental illness myself. That the idea of having risk associated with taking care of people with these illnesses is, a huge idea. I worry a little bit that there are a lot of folks who think that it's going to be like doing risk management for overall populations, but don't appreciate that this is going to, if they think they have trouble with engagement amongst the general population, they've got another thing coming when it comes to engaging this population. What are you seeing are effective tools to keep people in the boat, so to speak, in terms of their own care, which is, of course, is a precursor to any potential success that you can have in helping them change their lives?
Right. So, from the provider perspective, I think not every provider should be in this field. If you're going into this field because you want to make a quick dollar, don't do it. It will be a disservice to absolutely everyone, and something that it really, really troubles me. I think you have to go into this field because you understand the population and you understand the type of supports that they need. Whether those supports are all of the evidence based practices that we just talked about and pulling all of the other aspects into an individual's life, you're talking about treating an individual in a system that they live in a system of care. And that's hard work. So I think getting the right providers in place and getting the providers trained to fully understand what they're taking on. One provider can't do it. So, back to that system of care concept, inside the right kind of clinic, you should have the individuals who can do cognitive behavioral therapy or medication management working together as a team with physical health providers. From the individual's point of view, the risk is really high in leaving treatment and going back into their lives without the right kinds of social supports or really understanding what can trip someone up with addiction. And so, not only treatment, but education, psychoeducation around the disease, educating family members, educating supports, all of those have to get done to get to the best outcomes. I also want to bring in place the importance of using naloxone and having that on hand. So we see one of the highest times for death from opioids is in the few weeks that follow someone leaving treatment. They may not understand the biology of how much I used to take before I went into treatment. If I take that same amount now after having been off of opioids for some number of weeks or months, it'll kill someone. And they don't understand or know that. And so being able to teach the family and friends again and have naloxone on hand is part of managing that overall risk and, again, getting to the right kind of care that needs to be done.
I'm always surprised that we're still not at a point where we can deploy some of the remote monitoring technology through phones and other like Fitbit type approach to really connect people. If you have one of these illnesses, you're living with it 24 hours, 7 days a week. And the key is, to kind of have the alert on your phone to call your fellows in recovery if you run into a dangerous place, either because of where you are, geolocation, or because of other biomarkers that kind of a remote sensing technology could be able to pick up on, and then signal your designated kind of support team. Whoever gets that done, it seems to me, is going to be able to really move things forward. But I haven't seen it just yet. I don't know what you're seeing out there.
Well, I'm seeing components of it in different spots, but nothing together in a holistic app, for instance. So we're working with Neuroflow, a company who I think is well on their way to doing exactly what you've described. I always have a joke with their CEO, Chris Malero, because when I signed up for Neuroflow on my app, he now sees my steps every day. And he'll contact me and say, "Hey, you only did 4,000 today. What's up?" And I'm like, "I rode, I assure you, I did
Yeah.
something else." But the point is that technology is getting there. So if someone can say, Caroline only did 4,000 steps today, what's going on with her? And if that's a pattern, can do that in reach is really important technology for us to have, whether that information goes to the addiction provider, the primary care provider, the pain provider, or the case manager, or all of the above, so that no one falls through the cracks. Getting to geolocation is really important. So, back along the lines of contingency management and living in and being treated in the environment in which you shall return. If someone with an alcohol use disorder had always frequented the same bar, for instance, if you can use geolocation to say to that individual, "You're at a risky spot here, leave, call someone, do something else," to again have that information feeding into someone who will give an outbound call to the individual, whether again that's friend, family member, or case manager, or doctor. I think you have to pull all of it together in a cohesive view, and I think Neuroflow will be one of the first groups to get there, to really bring forward those types of things along with the work that they're doing with remote monitoring techniques for physiologic metrics and activity metrics, as well as behavioral assessments along the way.
Calling all mental health providers. Looking to specialize in treating adolescents? Check out Psych's cognitive behavioral therapy courses. Receive specialized certifications and hone in on your skills. Get 1-year access to patient videos and worksheets that you can email or text to your clients to keep them engaged in between sessions. Plus, you'll be placed on the Psych registry, where consumers in mental health who are searching for certified providers that are specialized in their condition can find you. To learn more about CBT for adolescent training, visit psychhub.com/learning. I love that you're thinking about all these things, and it's so forward thinking. I also really appreciate being in the education business that you are, very aware as we are, because we educate providers, but we also educate patients and families, and it is also important. So, kind of piggybacking on Patrick's point about sort of using AI and using technology, we're seeing since COVID, right, this huge, all of a sudden, telehealth and telemental health is just here, right? It was kind of a slow start, and then bam, it was here. And being that, we're very involved with different Medicaid and Medicare populations, we're seeing where maybe with Medicaid, they don't have the internet stability and maybe are, having a harder time, or with Medicare, as we're really learning a lot about that population, doesn't have the technology skills. I was just curious if you've had any thoughts about that, or if Magellan is kind of working on any of that.
Yeah, so I think of an omni-channel approach. And so I am a non-believer in one size fits all. It's not ever going to work that way. And so in an omni-channel approach, you look at your population in terms of engagement and say, okay, for a Medicare population, there will be people every day aging into that population whose skill set will be ahead of individuals who have been in Medicare for longer and are older in age. So you can't think of the Medicare population as a uniform, all the same. So let's look at it as a diverse group of individuals of varying income levels, varying education levels, varying social circumstances, and varying access to technology, whether limited by not having the tech or knowing how to use the tech. And so that first thing I think of is all of these populations are heterogeneous. So let's look at them to see what channel we need to reach out to them. Maybe it's a Zoom phone call or a telecall, but let's make sure that the individual feels comfortable in the way they can be reached. And then start working toward training them in technology, whether it's simple as simple as texting and starting with texting, all the way to being able to be trained to use the apps. And I think an app has to be easy enough and intuitive enough in the programming that it's offering to be usable by whatever population you're directing it towards. So if I have something really complex, I, as the health plan or care manager, case coordinator, whatever, shouldn't be giving that out to the wrong person. It won't get used. It will be a waste of resources and will provide further frustration for that individual. So omni-channel, heterogeneous group, putting those two together will help you align the right service toward the right population.
I love the holistic approach you take to everything, and because it is true, and there's no silver bullet, and there's no one way, and it's very thoughtful and intentional the way that you can think through the different components. I know that Psych Hub and Magellan are working on some collaborative care work together. Collaborative care is kind of this buzzword that we hear a lot. And Magellan is really leading in those efforts as a just kind of trying new innovative ways around that. Would you mind sharing with our listeners about really just starting from the beginning? What is collaborative care? Why is it a problem? And what are we doing now and where do we need to go?
Absolutely. So, collaborative care is the way that I like to phrase it is one of the best ways to ensure not only access to care, but availability of care. So, step back and think about where we are as a country today. We're still heading toward our nadir in the number of behavioral health professionals available to match the need in our population. And we're not expected to be out of that nadir for probably 10 more years. And so we have to think about how do we reach individuals and get them evidence based practices wherever they are. And most typically, that's going to be in the primary care office or in a specialty care office. So, collaborative care is the way to provide support and evidence based practices to those frontline providers seeing individuals with mild to moderate or even moderately severe conditions. So, in the United States, collaborative care has been actually studied for years, but it's always been clunky because it's been kind of like I'll come into my doctor's office and I'll fill out a depression screener, and then maybe the doctor will see it or not. And maybe they'll address it during the clinic visit or not. And maybe something will happen and the individual will get the right kind of care. Um, Collaborative care provides the support to ensure that the screening is done, the results are monitored and followed, the right treatment happens, and the individual is followed over time. In the case of Magellan, we wanted to think about how do we bring this forward. And so we partnered with Neuroflow. I mentioned them earlier. Neuroflow, in my mind, after looking at many companies, brings best in class services to this because they have a dashboard that is seamlessly integrated into the medical record, the EMR, as well as into a case management system. So case manager, care coordinator can see all of the information coming in. The member or the patient uses an app for assessments. So all of that information is automatically loaded and it becomes seamless over time. The individual is able to get support back, texts or messages being pushed through the app back to that in a very individualized way. So that's kind of the first part of what we're doing. The second part is then providing a psychiatrist or other behavioral health professional in the background. So when that primary care provider reaches the complex patient or reaches a patient who's not getting better, we can case conference either through the app and the platform or telephone or a Zoom call to link the primary care provider with the psychiatrist and get that kind of expert care. So instead of having 20 patients wait in line for a psychiatrist, we can take care of 20 patients at once with that kind of feedback and that kind of knowledge coming in about how they're doing. So we expand availability of care. which is really important to me. So I don't want someone waiting and waiting and waiting to get into an appointment. I want to ensure that we can start the right kind of treatment, start giving them supports while they might wait for a higher level of care, or maybe it will turn out they never actually needed that higher level of care and can be treated in this way. Why is that important? So let's go back to availability. If we have those same 20 patients going to the psychiatrist, but maybe only three of them actually needed it, we've lost 17 spots for 17 individuals who need the level of care that a psychiatrist can bring. So, collaborative care not only puts the right kind of tools in the primary care provider's hands, the best evidence based care going to the patients, it solves availability of care across the board. So we are all in on collaborative care, huge believers in collaborative care and using technology to extend it and build on the incredibly strong evidence base that's already there for it.
Well, it's great to hear the Kennedy Forum, which we started on the 50th anniversary of President Kennedy signing the Community Mental Health Act. It was one of our principal goals to get those G codes turned on. And remember, with Patrick Conway at CMMI, we really pushed. And, because mental health doesn't have the kind of advocacy, lobbyists, if you will, like banging on the doors in CMS and other places, often, they don't get given the choice, that there are changes we can make to the way CMS reimburses things. I'm hopeful that we can increase the collaborative care code substantially under the new administration, because, as you know, the uptake on it is less than optimal. And the need is so great. I'm a big proponent of primary care for all. I think that should be our first objective before Medicare for all, because it's doable and it will solve the availability issue in real time. And it'll also solve a lot of other problems for people, especially in this public health crisis where they're not tied to a primary care physician and those primary care physicians don't have the teams around them. It seemed to me on a system-wide basis, this is affordable. I've seen it, in my little state of Rhode Island. It can be done. So I appreciate your passion on that. But I still am just so frustrated that with the pandemic, we have not taken up the epidemic within the pandemic of suicide and overdose and depression, anxiety. And I know you've spoken out on this, but just if you co-located with the vaccination, some information resource hub, to the point that we've been discussing, you would make the case, as you've done, as I've seen online, that mental health is part of your physical health. And what better opportunity to do it than to signal that when we're reaching out to save your life from COVID, we're not forgetting that your life may come to an end tragically because of the increased number of suicides and overdose as a direct result of COVID, because you self-medicated in order to deal with the isolation. So anything that Magellan through Centene and your other connections at the APA and so forth can do to push that concept is we've really just scratched the surface of the number of Americans who've been able to get vaccinated. Many more will be coming back for their second dose. I think we could easily embed some information that will allow people to go home and do a screen online if they're connected, or you have a brochure that they should not blame themselves for feeling the way they do because of this year that they've been through has been so traumatic. Could you talk about the need to kind of integrate, and especially during this pandemic, not to do this sequentially, but ideally concurrently?
Absolutely. And then I'll talk about a couple of things that we're actively involved in working in that area today. There has never been a more perfect storm, right, for this to happen. We already had a looming mental health crisis in terms of lack of providers. Add COVID to the mix with people losing their lives, people with existing behavioral health conditions having worsening of their symptoms, the new onset of symptoms for many, the particular toll it's taken on adolescents and young adults, on those individuals who are caregivers, on women who have lost their jobs to stay home and homeschool kids during this time, the economic hardships brought on, and the loss of so many important life events for so many, tragically, funerals, weddings, graduations, proms, you name it. All of those things create this perfect storm for mental illness to fester and unfortunately flourish in a terrible way. So to that end, I think you look at the stigma has been reduced because of COVID. My fear is that will swing back, and I don't want that to happen. So, as much as we can do to continue campaigns around stigma reduction and campaigns around normalizing what it is we're experiencing and getting the message out that it's okay to admit that you feel lousy right now or you feel additional stress right now, and where to best direct that. So let's go back to the example of, do you talk to your primary care provider? Do primary care providers have the tools to take care of that? How do you get symptoms treated, cared for? What do we need to do there? And so that's part of it. So stigma, getting the right kind of treatment available for individuals. So once they get past that block that says no, everyone else feels rotten too, so why should I get treatment? Everyone then should still get treatment. Um, that part of it is critically important. One way, Patrick, that we've addressed it is through the concept of loneliness, right? So if someone doesn't want to admit that maybe they're depressed, loneliness is an amazing construct to use for that kind of in reach to individuals who may be feeling demoralized, and all the steps along the way to depression. And loneliness is a key one of those factors. You can be in a room full of people and feel very lonely, or you can be socially isolated and feel very lonely, but it's an incredible construct to really use to reach out to people. We have been engaging in a campaign that we started with our MRX Cares program. MRX Cares takes care of individuals who have oncologic diseases, neurologic diseases like multiple sclerosis and other immunologic diseases, individuals who are at very high risk for COVID and the effects of COVID, and we knew would be social isolating. So, taking that very data driven approach, found these individuals by identifying them through what medications they were taking, and then did an in-reach program on loneliness. And what we found were incredible results. We had people drop out in the first couple of weeks and then never again. So we retained about 80% of those that we reached for the full scope of the initial programs. And at the end, what we found was something that made me so happy, that those individuals who had the highest satisfaction with the program and benefited the most from the program were also the same group that had the highest level of burden of social determinants of health. So we were reaching the people who really, really needed that help and that kind of support. So it's doable to take other kinds of constructs than saying it's behavioral health or I'm tough, I'm okay. Let's enter and get into that individual, perhaps through their medical illness. And then the example that you brought, if I'm coming in for my vaccine, there is never a more captive audience than now to do that kind of screening. So creatively pairing those two together to find those individuals. I think part of what should be added to your idea is building in the national suicide hotline number to that kind of information as someone gets their slip afterwards saying, this was what your vaccine was. Let's build in that kind of education at the same time. We still have millions and millions and millions of people to reach with the vaccine. So there is time to do this.
Well, Dr. Carney, we're going to do that together.
Let's do it.
And we'll make this program the kickoff. But we have a program, that we've just some graphics we've put together, which we'd like to send you, saying mask COVID, not your feelings. Mm-hmm. And having some resources available. Would love to. I've talked to some of my friends, good friends with the Lieutenant Governor of Delaware, obviously the Governor of Rhode Island, Massachusetts, Connecticut, New Jersey, where I live now. And I'm really going to look forward to just trying to get the poster boards. You know, when you go in your primary care doc's office, they have the poster board of the person with a stroke, you know, so you know the signs. And we just need to make this a public health campaign, and it shouldn't cost us anything. And like you said, it doesn't preclude a more deeper dive after you subtype who's highest risk for health plans to go and really, but it would be part of a broader effort to really seize this moment in time. And
Absolutely. And I think as kids are coming back into school, I know from my own daughter's experience, she's anxious. She says, Mom, when we were there those 3 weeks before, kids weren't wearing masks. Substitute teacher comes in a room, doesn't wear a mask, and the kids' level of anxiety starts increasing, not creating the right environment for them to be in school, nor is staying home. So if we can get that kind of education out about those sorts of things, it would be incredible. Those kinds of campaigns. I'm with you. Let's do it.
And we're proud that Magellan is a partner in our COVID-19 mental health resource hub. We have about 30 partners of all kind of giving resources for a single place that's unbranded, but just a place where people could get that information. And, you know, it goes back to what you said earlier. We really can't minimize the importance and value on resources and information, because even though we might not reach people who are already in acute crisis, there's so many on the early end of that spectrum that we can reach. And training people and educating them on the types of care. I mean, you've mentioned evidence-based practice and evidence-based interventions many times. We preach it all day long because we're in the business of training people on it. But I'll tell you, there's not a day that goes by that I don't explain to people that behavioral health providers are pretty much generalists. And we, myself included, we treat everybody the same with the same interventions, and that there are these evidence-based interventions that are called evidence-based because they're proven to be more effective at matching symptoms. And I always use the analogy of imagine if you went to an oncologist and they treated every cancer with the same chemotherapy. And people are just kind of blown away. They're like, well, I didn't know that. I just assumed that my therapist, was using the best intervention to treat my bipolar, my eating disorder, or my substance use, or my whatever, even complicated grief, whatever it might be. And yet it's not therapist's fault either. It's like the whole system is really pretty broken. And when I just listen to you, I feel so encouraged about the future of mental health, which is why we had you on.
What I think is so incredibly important there is something we started. So another partner that I work with is Arene, and Arene is a data science company. And they kind of grew up in the pharmacy world, which is why I first learned about the work they were doing in that space. And we really put our heads together to come up with, how do we take this really amazing work that we're doing for Magellan RX and use it for our clinical programs. So we grew a bunch of programs there, and then I carried it over to behavioral health. So one of the things we're doing with them now is we have a suicide risk score. And in that population, I can run data and identify who the individuals are with this score at highest risk. And my care coordination teams are now reaching in to those individuals and starting to put the kinds of supports around them that they need.
Wow.
So data science leading the way, and going back to something I said earlier, we cannot take a homogeneous approach toward heterogeneous populations. And so by being really targeted, you can get the right services to individuals who really would benefit from that outreach. So if we build on the COVID idea, looking at populations who would be very high risk, let's see what their scores look like. Let's try to understand them better to ensure that we can prevent demoralization all the way to suicide from happening.
It's such a great point. And when I hear you say it, I bet there are people that would think, oh, that's got to be so expensive as to reach each person individually. But when you peel it back, it's not. It's actually more cost effective because you're getting people the right care at the right place with the right to your psychiatrist collaborative care model. If there's 20 psychiatrists, but only 3 of them really needed it. I mean, but it is people are so reluctant to really customize care or personalize care, and I don't know what it is that we tend to go to this homogeneous approach, lumping this group together for this and whatnot. So we're all very lucky to have people like you at the helm of these, these organizations that can make a huge difference. I mean, how many lives do you know that Magellan is doing behavioral health for?
Uh, Today we are reaching through Magellan 1 in 5 Americans through one program or another.
Wow.
The number of just behavioral health is much smaller than that. But the truth is, inside Magellan, my teams have been able to get behavioral health services in places where they hadn't been before. So, behavioral health services directly into the PBM business, for instance, or behavioral health services into the utilization management business because we can identify individuals there. And so the company has been really forward in its thinking about how do we take these programs and get them in places that you typically wouldn't see behavioral health being delivered. And in my mind, with stigma that unfortunately is still there, diminished because of COVID, but absolutely still there. There's no better way to do this than to look at a holistic way of delivering care. So you don't have BH here and physical health here. It's a holistic package of care.
I love it. I love it. So one in 5 Americans can have the opportunity to be touched by your great leadership and all of Magellan and all the great things that all the people are doing there to move the needle. So we're really grateful. We'd like to wrap up each one of these episodes with asking a question. If you had a magic wand, what would the future of mental health look like to Dr. Caroline Carney?
I think the future of mental health is really incredible. So, not only do we have the kind of tools in hand today that will help treat mild and moderate depression, anxiety, and other symptoms that individuals may have before they develop into full fledged disorders, if you will. So, we have great tools today. I think the place where we really still need to focus is on how do we take care of individuals with serious mental illness and addictions in a much more holistic fashion. Maybe that's going to be through the use of virtual reality. Maybe it's going to be through the use of better applying science where we understand what the biome contributes to mental health, where we understand what immunologic conditions contribute to mental health, where we understand how brain science is driving that. All of that being said, there are many social determinants of care that we have to work on, not necessarily as a doctor, the health system, the health plan, but going back to the very beginning of this conversation, as a community, as as a state, as a nation, how do we address some of these underlying problems that really continue to fuel the mental health crisis in America? Those are key. And so my magic wand would be, let's fix some of what's troubling society right now so that we can have a better foundation from which to work.
I love it. That's beautiful. And I hope that all of those dreams come true, as we all do. But we're getting there. I mean, we're slowly making progress. So thank you. This was incredibly interesting, informative, insightful, and I learned a lot. And I just think that stay passionate and don't give up, and we're gonna get there. So thank you so much for joining us today.
Yeah, with partners like Patrick and Marjorie and Psych, there is nothing else but staying passionate. The work that we can all do together, it's what gets me up in the morning and keeps me moving forward because I know that the right people are taking this all in the right direction. And I am very grateful to be part of your team.
Oh,
Likewise.
likewise, exactly. Thank you.
Thank you.
What's cracking, Hope Nation? It's your friendly neighborhood Kevin Hines, and here is your Psych brain health tip of the week. Be giving. Give your time and your energy to a cause outside of yourself. It is so important to give back. It gives us a sense of purpose, personality, and the feeling I get when I have helped someone out is unparalleled. Plus, research shows that people who have volunteered for a cause have lower levels of depression than those who don't. If you're looking for organizations where you can volunteer your time, check out psychhub.com/partners. Psych has an ever-evolving list of 500 plus nonprofits, associations, and more you can use as a starting point to find organizations that you are dedicated to improving, and then you can thus improve the mental health of others and yourself.
As always, thank you for listening to our podcast.
If you enjoyed the show, drop us a review.
If you haven't already, subscribe to our podcast for the latest episodes.
For the latest insights, check us out at psychhub.com.
Looking to grow your behavioral health practice and reach more clients who need your help? We have just the solution for you. Psych Hub Provider Learning Hubs are your answer. We will train you in the greatest information on evidence-based practice delivered by industry experts in a state-of-the-art way. And at the end of it, you will earn a certification in how to use these interventions to treat anxiety, depression, insomnia, you name it. And then when you finish, you unlock a whole library of resources for ongoing learning for you as the provider, but to share with your patient. How great is it to let your patient know in a quick video, here's what to expect from your therapy session. And then any exercise or activities that happen in session, we have videos to help reinforce those skills at home for your patients, as easy as just sending a quick text or emailing them. It is a revolutionary new way to really get people through treatment, getting the best symptom results, and engaging your patient along the way. Visit psychhub.com/learning to get started.